So, Rajen, do you have any experience with the use of ICG?
No, sir, I don't have any experience. Basically, because the fluorescence laparoscope is not cheap. Many of the centers where I've worked in, they don't want to buy expensive equipment. Even CUSA, they're unwilling to invest 35 lakhs in it. So I've been doing cheliclesis all along.
Okay.
So that's about it. So ICG in cirrhotics, I haven't operated any cirrhotics. I've operated mostly normal livers with tumors. So the issue of using ICG doesn't arise.
Yeah, but a lot of people are now using it as a routine during laparoscopic cholecystectomy for delineation of the biliary ductal anatomy.
Yes, they are. But you require the fluorescent laparoscope.
Yes.
That allows you to see the ICG in the first place. So that is a very expensive. That's, I think, 20 lakhs or something.
And the other thing is that you will have to inject it in every case because you have to do it before the procedure starts.
Yes, almost 1 hour to half an hour before the procedure starts.
Yeah, so because you don't know in which case you will need it, so you have to do it in every case.
Yeah,
So that's the only difference between it and intraoperative cholangiogram, which you can use selectively depending on when you require it.
Unless the bilirubin is raised, we don't venture to do cholangiogram unless LFTs have come abnormal. And in most of the time, I believe these are invasive procedures. So I do an MRCP the day before surgery. And if that is normal, then we don't do any scoping because it means the stone is too small to matter. It will just be passed away. I haven't had much problems with that kind of strategy, so I'm continuing it.
Yeah, but there are two issues. One is cholangiogram to find out CBD stones, where you can use the criteria for to say whether there is a low, medium, or high risk for CBD stone, and you can use it only in medium and high risk. On the other hand, if you want to use intraoperative cholangiography for delineation of the biliary ductal anatomy to avoid an injury to a normal or an aberrant duct, then you have to do it in every case.
True, sir. I think it's a safe policy if you can afford it. And otherwise, it shouldn't be a problem. ICG per se is not very expensive. But the equipment you require to visualize is very expensive. So that matters. Because the best job possible with the least amount of facilities. You, on the other hand, have had been fortunate to work in centers which are willing to invest. But I have mostly begun departments in various hospitals and then handed it over to a younger junior and then moved from there.
So we have a few students online. Any of the students, would you like to tell us of some situations where you can use ICG during surgery? Any of the students would like to come in? Just unmute yourself. Siva Subramanian, can you tell us any other use of ICG?
In case of major liver resection, we like to do
for what?
Bile duct delineation. For bile duct delineation for during resections. Even for during resection, we can use for demarcating the line of resection. Also, you can use ICG.
No, so these are two different things. One is a biliary ductal delineation, other is a vascular delineation.
Yes, both the things. Both the things you can use it.
So how does the use of ICG differ for both these indications?
Depends upon the duration in which we give the drug.
Yes. So as we were discussing, for biliary ductal anatomy delineation, you need to inject it quite some time before, whereas vascular delineation will be immediate. So these are two different timings. Any other procedure? Any other student would like to tell us where ICG is now being used?
Sir, it can be used whether clear ICG clearance test can be used, whether we can go ahead with a liver resection or not, sir.
Okay, so that is ICG clearance. That is
Yes,
a functional use of ICG.
yes, sir.
Yeah. So can we tell us a little more about how it is done and what is measured?
Sir, the time required for the ICG to be cleared, amount of percentage is cleared in the given time, sir. Less than 15%, if it is there, it is considered to be normal. ICG clearance from the liver parenchyma. Hello, sir, am I audible?
Yes, yes. So can somebody tell us in a better way or in more detail that what time?
Sir, sir, shall I?
Yes.
There should be more than 90% clearance in the initial 15 to 20 minutes, sir. More than 90% clearance should be there.
What is the standard time at which ICG clearance is measured? ICG, then we put a number. It is usually 15 minutes, isn't it? ICG 15.
Yes, sir, 15 minutes. ICG 15, yes.
It is the 15-minute clearance.
Yes, sir.
Any other procedure, any other structure which can be delineated?
For delineating colonic vascularity also we can use it for during versus the vascularity of these.
Yeah, I think Dr. Srikanth has joined. I think I will hand over to him. Yeah, Srikanth, please start your. So in addition to the hepatobiliary system, it is being used for delineation of the thoracic duct. It can also help in delineation of the ureter. So there are several uses. And as you said, to assess the vascularity of the colon, to assess the vascularity of the gastric conduit when it is being taken up. So there are several uses, but depending on what structure you want to see, the timing of injection of ICG is very important, and that is what I wanted Dr. Srikanth to elaborate on. Yeah, I think, Srikanth, can you hear me?
I can hear you, sir.
Okay. So we were just, before you joined, we were just discussing with the students that what are the various situations. So can you please elaborate upon the timing and the dose of ICG contrast when it is used for biliary ductal delineation and for vascular delineation in liver?
Yeah. So I'll just give a brief, sir, a little bit. I think.
If you want to show something, please share your screen and maybe you can start.
Yeah. Is this visible, sir? Is the screen visible?
Can't see. I'm on a mobile phone, but I can't see.
Okay.
It's not visible, sir.
Zoom. Can you see this? Is this visible? No.
Sir, you can stop sharing first, then again share screen, sir.
Okay. So while I do this, I'll. The thing is, ICG has been used in the last more than 3 decades. From our training times, it was mainly we used to read it basically for liver function assessment before surgery. So that's a time when its application was limited to ICG retention test. And then subsequently, 2008, it looks pretty recent, 14 years before, is when the first description for gallbladder surgery was made. And then same year, Aoki had described it for liver tumors. So how they found out was it was serendipitous in terms of they did the ICG retention tests, and some of these patients during surgery, when they used ICG fluorescence cameras, they could find that the tumor retained the fluorescence. So they found that interesting and then worked on it subsequently, and a lot of things have come up. So with regards to the dose that is given, the
Sir, your
vial
screen is
itself.
not visible, sir.
Am I audible?
Yeah,
Yes,
yeah,
you are
we can
audible,
get.
but your screen is...
Okay, share screen. Host disabled participant screen sharing, it says. Is the screen shared now? FaceTime HD, choose visual background, choose video. Video, this is fine. It says host disabled participant screen sharing. So can you enable
Anand, you
me?
will have to enable Dr. Srikanth to share the screen. Or maybe the Dwarika Clinic team. Can you allow Dr. Srikanth to share the screen?
So the dose that the vial, the ICG vial contains 25 milligrams. That's the standard dose in which it comes. So it comes in the form of a powder. It looks greenish, but it's got that the bottles which need to protect against sunlight are a little dark. So these are brown bottles. The dilution solution is about 10 ml. It comes along with the package. And since ICG has particulate matter, when you inject the 10 ml into it, so the 25 milligrams gets diluted in the 10 ml. So each ml has 2.5.
Srikanth sir,
Yep.
Srikanth sir, you are co-host now. You can share the screen.
Yeah.
You can share the screen now. Just click on the screen.
So can you see the screen now? Security, this. Is it shared?
So click on the share. No,
Post
click on the
only
share screen, sir.
all
Share.
participants. So I've clicked on all participants.
Yes, sir.
Who
Yes,
can
sir.
start sharing when someone else is sharing? All participants, I've said here. Post only. So is it visible now?
No, sir.
Advanced sharing options. So all participants. Who can share? All participants.
Sir, in your home screen, you can see a green sign share with
Yeah,
arrow.
share. So when I click on that, it says
Click
whiteboard.
on-
It says universal access. So if I say universal
No, sir.
access,
When you share your screen, click the window which you want to open. Click your presentation. Then we can see your presentation. In white window, you can see your presentation.
Srikanth sir,
yeah.
Srikanth sir, rather than clicking on arrow, you are supposed to click on share screen, that green article.
Yeah, share screen. So I press.
Then a
when I
separate
press share
white window
screen,
will open.
Yeah. So it says host only. Who can share? All
No, sir.
participants.
No, sir. If you will click on the arrow button, then this window will pop up that who can share. Rather than clicking on this, you can share. You have to click on that share screen green line.
Yes. So when
Then a
I say
separate
that,
white
it
window
says
will open.
whiteboard and says share.
Whiteboard ko you have
Yeah,
to
sir.
click.
Okay.
Sir, now you
Whiteboard.
have to open. Now you have to open your PPT in this. Background mein, first of all, you have to open your PPT. Then it will show in this white window.
Okay. Let me see that cancel, sorry. PPT. Okay. Now if I say share screen and say share. It's a Mac I just opened, but it doesn't, it just opens that. So I click on that whiteboard, I say share, open system preferences, security privacy to grant access.
And maybe we can just continue to discuss. So you were telling us about the dilution, and then what about the timing of injection, depending on what we want to see?
The timing of injection has been controversial, but what is considered reasonable for gallbladder surgery, for example, is about 1 hour before 30 minutes to 1 hour. That's what was the consensus. And the consensus statement came out saying 30 to 1 minute, 1 hour before surgery. So there have been studies. What's the dose? 2.5 milligrams. So 25 milligram is there in a vial, and 10 ml, if you dilute it, 1 ml of it has 2.5 milligrams. So that is given intravenous half an hour to 1 hour before surgery. It can be given 2 hours before. People have tried it many, different timings, like 3, 6, 9, and so on. And some have given 25 milligrams 24 hours before. The patient gets admitted the day before, and they give it, and it's 24 hours post. But most groups would agree. In fact, all the studies, if you put together one of the meta-analysis, 2/3 of the studies show 2.5 milligrams 2 hours before was the dose in one of the meta-analysis which was published about 2 years before. The consensus statement, like I said, half an hour to 1 hour. So this controversy exists, but our personal experience has been 2 hours before surgery. That means when you shift the patient to the pre-op recovery, we give it before shifting to the pre-op recovery. So you can never mark it out and say 2 hours. I would think it's roughly 2 hours before surgery is what we have found, 2.5 milligrams. So what happens is within 5 minutes, 95% of ICG is taken up by the liver. And then you start having excretion, rapid excretion by 15 minutes to 30 minutes into the biliary system. And approximately 3-4 hours later, you don't see much fluorescence in the biliary tree. So the time frame seems to be between the 1 to 3 hours time that you should be screening the biliary tree. So you should time accordingly. So depending on the system, depending on how much time it takes for shifting, etc., I would think an hour before is what is recommended and is what should be done. Now, giving on table at the time of induction, that would not be, because when you put the scope in, it looks all green, because by then liver has taken up, it started excreting into the extrahepatic biliary tree. And so the background noise from the liver would interfere with your assessment of the extrahepatic. Although it is in the extrahepatic biliary tree, the background fluorescence from the liver will interfere. So it should be 1 hour beyond. We've been using 2 hours prior to surgery, and we've had good visualization of the extrahepatic biliary tree. About the vessels, when you inject, you screen, it has to be immediate, which means you give an intravenous injection, And you need to assess within a minute, because it's just about going to the heart, and then you have with the next systole blood getting into the vessels that you're screening. This was typically used in ophthalmology. It's used for aneurysm surgeries in neurosurgery. And then it was recognized that you could use it because it's taken up by vascular tissues like parathyroid. So it's used in parathyroid surgery. So pertaining to hepatobiliary, for gallbladder, it is 1 to 2 hours before. For liver itself, I mean, you don't have to, you're not assessing, you're assessing liver tumors. So it is typically retained in the hepatocytes within the liver tumors. And the reasons, there are many reasons which have been shown why it gets retained in the, like HCC, it gets retained. Because there's a problem of, there are no biliary canaliculi in the hepatocytes which are there within the, dedifferentiated, undifferentiated, whatever, in the HCCs. There is no biliary canaliculi to excrete, and so it gets retained in the tumor. So how long it gets retained? Maybe up to 2 weeks or longer also. And what about, you don't have hepatocytes in a metastasis? Then why do you have fluorescence in the metastasis? In metastasis, it typically around the rim of the tumor, and it's been postulated that the tumor would compress the parenchyma around, and the biliary canaliculi around are unable to excrete like normal. And so the hepatocytes around the metastasis would retain the ICG. And for when you do it for a HCC, typically 80% of them have a cirrhotic background. You should give it 48 hours before the planned surgery if you want to visualize the tumor region to aid you in the margin for resection, etc. For metastasis, it's all right to give it the day before, 24 hours before, because in cirrhotic liver you have other nodules, dysplastic nodules. You have the tumors getting the ICG getting retained in those dysplastic nodules too, and so the differentiation from the tumor itself becomes difficult. So if you want to see the tumor, HCC 48 hours before. Many people would suggest, many groups which have been doing routinely would say, when you do the ICG retention test, and at the same time, the same thing would be visualized during surgery. So they do it as much as 2 weeks before the planned surgery. So for liver tumors, more than 48 hours before, particularly HCC, 24 hours minimum if it is for a metastasis. For a HCC, it is a uniform kind of uptake which is seen. For a metastasis, it's a rim fluorescence that is seen. For a HCC, although we say uniform uptake, again the differentiation has been made into based on the differentiation of the tumor. If it is well differentiated, it takes up uniformly. Moderately, it takes up partially. And there could be rim fluorescence also with a very poorly differentiated hepatocellular carcinoma. Now, when we have used it in other locations, and these are interesting applications in GI. One is use in cardiomyotomy. So there, you want to study the myotomy site.
Sorry, let me interrupt. So two questions before we go on to other. One is, so you said that the vial contains 25 milligram, but you are using only 2.5. What happens with the rest? That goes waste?
It goes waste, sir. So I think if you are using it in a setup where there are going to be a couple of gallbladders done, I guess it could be used. We have never done it like that. We have used an independent one vial for each patient, even when we have had 2 or 3 in a day. So, but yes, it goes waste. So then why is it designed? We don't have the utility so much that they have come up with lesser 5 milligram vials or so on and so forth. So it's been a standard in India, just for people to know. It's manufactured in Madurai. I think because its use was mainly in ophthalmology, retinal surgery, etc. Madurai, there is a manufacturing unit. Oro Green is the name of this. And it costs 1,000 rupees, 1,200 something. So, yes, sir.
Second
it goes
question.
waste. Now,
Yeah.
if you see for a liver tumor, I didn't say this. You will have to the amount given is again variable. People have quoted 0.2 milligram per kg, but the others have said 0.35 milligram per kg. So it works out to roughly around 18 to 20 milligrams. So when you're giving it for a liver tumor, you would be using essentially a larger part of the vial is utilized when you inject. So when you inject 48 hours before, you are injecting out of the 10 ml, 8 ml, if it's going to be 20 milligrams.
So for a laparoscopic cholecystectomy, that means if you want to use it, it has to be given in every case because you have to give it before the operation starts. So
Yes.
it cannot be used selectively, isn't it?
If it's the same day you are doing some patients, I guess the vial can be kept, but the way it is described, once it's diluted, discard it.
No, I'm saying that because you want to use it to delineate the biliary ductal anatomy,
yes,
you will have to give it in every case because you don't know which case is going to be easy and which is going to be difficult.
This is important, sir. See, whenever I have, this has been recent. Whenever I've been speaking, most of the groups which are not using, they use white light. We all use white light. So their question is that where you want to identify, like for example, in acute cholecystitis, the imaging sensitivity seems to be a little lesser based on data. And in the regular lab chole, we don't need because we have safe techniques already. What is the use? And this kind of questioning. But the different spectrum that we have we have found is only because of the routine use. So I would say when you have this technology, routine use, because gallbladder comes out with a lot of surprises during surgery. You do all your screening, we do the risk assessment, who will have conversion higher, and so on and so forth. So you should use it uniformly. And that's when more data will come in as to in specific situations where it can be. That's a very important thing, I feel. Most of the studies designed also seem to talk about either asymptomatic or acute cholecystitis kind of subgroup. You can't go and say internal fistula subgroup because that comes up only when you use it routinely. There is going to be a small percentage who have these.
And also aberrant anatomy can be present in any gallbladder.
Any gallbladder, agreed, sir.
I feel that there are two major uses of ICG. One is to, in a difficult pathology, to delineate where the CVD is. That maybe you can predict to some extent. But the second important use is to delineate the aberrant anatomy, which can be there in any gallbladder. Which means that you have to use it for all cases.
You should use it in all cases. That's what I would think. Based on whatever we have been seeing, it should be used in all the cases. Because data, when they look specifically at uncomplicated gallstones with white light, maybe they couldn't come up with so much of information from the numbers. They should study that. Yes. At the moment, you need data which is more widely placed, all inclusive. Patients should be all included and then take out the inferences from there. But the
second question is
comparing.
The second question is about liver tumors, whether primary or metastasis. So what is the main advantage of using ICG, that you stay clear of the tumor and have a good margin, or what? Or is it for identification of undetected tumors?
So I would say it is for both. Now in that, I would put it like this. If you are going, it definitely helps you with the margin, particularly when, we've had instances, that's where some of the videos, maybe I'll post it later. These videos clearly will demonstrate that in a cirrhotic background, the tumor edge is not seen. You can't see the tumor edge clearly. But when you have the fluorescence seen from the tumor, you know how far to keep away from the tumor. So most of our inferences at surgery would be drawn from the pre-operative imaging. But on the road, when you want to assess, right now we have ultrasound as a tool. And this was a question raised and we had discussed recently in that meeting, that ultrasound, to use it simultaneously and keep operating becomes a little cumbersome. But here it's a visual aid that you have a fluorescent thing and you're keeping away. And I think both should be used complementarily, but keeping away from the tumor area. So keeping
it will be useful. It will be useful only if you are doing a non-anatomical resection, is it? like a metastatic?
I would think it is useful in anatomical and non-anatomical, because when you plan an anatomical resection, as you go in the parenchymal transection plane, the moment you are close to the tumor in the transection plane, I mean, there are going to be, I mean, if it's a standard anatomical with the tumor well away from where your transection plane is, maybe relevance may be less. But if it's a large tumor and you are worried about the tumor coming in the transection plane or proximity, to keep away from that, again, it guides you during, because you start seeing fluorescence in the transection margin. So I think it helps there. Again, another important thing is multicentric lesions. Particularly in the metastatic group, you asked what is the additional? The metastasis group, additional lesions have been picked up on ICG. So you're given ICG before, you know where it is on the preoperative imaging, the lesions. But when you put in a scope and see the pickup has been up to 15% more lesions, which means you might find 2 lesions on the pre-op imaging and you find another lesion. So that kind of a situation happens in up to 15%. That means particularly surface lesions. And somehow majority of 80% of lesions would be somewhere within a centimeter from the depth from the capsule. I mean, you could have deep lesions, you won't see it on a fluorescence. It should be 8 to 10 millimeters from the capsule. So new lesion pickup is something with ICG, even after use of intraoperative ultrasound, which means it is standard to use pre-op imaging and intraoperative ultrasound. Use intraop ultrasound first screen to rule out additional metastasis. In addition to that, ICG would pick up more lesions. So I think for metastasis, the role is also in detection of new lesions. And also, if it is a metastasis, the recommended distance from the edge of fluorescence is 1 centimeter. Whereas with a HCC, this is a consensus for most of the surgeons after having used it and then review your specimens, I mean, histopathology specimens, and say margin, distance, etc. While you can stay along the fluorescence with a HCC just away, it should be minimum 1 centimeter away to have a R0 resection. So it helps in getting R0 resection with metastasis too.
What about the vessels? When we inject during surgery, which vessels are delineated? Is it the hepatic artery, portal vein, or hepatic vein?
Yeah. So here, I think the detailed descriptions came from Ishigawa himself, who used it for 2008 for lab coli, but subsequently 2008 Aoki, he first demonstrated for tumors. But 2012, Ishigawa's group demonstrated 2 distinct staining methods. They described it as positive and negative staining. So positive staining would be that you inject into the portal pedicle, I mean, the portal vein of that particular segment, subsegment, or sector, if it is a lesion that they want to resect. So here the caution is that you have to have ultrasonologists with good experience, or the surgical group itself with good experience in seeing that portal pedicle, inject into that portal vein, and it's a small dose, 0.025 milligrams per kg, very small dose per ml, 0.025 milligram per ml. So you inject slowly because you don't want backflow of it. If you inject fast, it goes into the other portal vein. You're not occluded anything. You just inject into the portal vein, portal pedicle of that tumor-bearing segment, and it just flows into that segment, and that segment alone lights up, basically. So if you're doing a segmental resection, a non-anatomical resection, if you want to plan within the sector which lights up, but tumor-bearing area, etc., guided further by intraoperative ultrasound, whatever. So this is positive staining. That means you're staining the tumor-bearing segment. So you inject into the portal vein, ultrasound guided. So the guidance, the expertise should be there with intraoperative ultrasound in localizing that particular portal pedicle tumor-bearing segment. Now, in negative staining, what happens is, supposing you're doing a left lateral sectionectomy. This is just for discussion. It could be used in any segmental resection also. So when you get to the portal pedicle, once you clamp the portal pedicle, give intravenous in this case. The dose given is 2.5 milligrams, which is given in gallbladder. So then what happens is the flow is occluded to the tumor bearing area, and so the normal liver lights up because it's rapidly taken up within 5 minutes into the remaining liver. And so you know the demarcation, what's the transection plane that you need to go to, and so on and so forth. So many times when you clamp the artery and vein, you get the demarcation, but the clear line of demarcation, that's where perhaps it would help more. And we don't have a personal experience in this, so I can't comment more on how exactly it is helping. But what I can make out is the line of demarcation is going to be crystal clear as to once you occlude the tumor-bearing portal pedicle and inject intravenously. So, positive
now,
staining in tumor-bearing segment, negative staining systemic. You're injecting systemic, occluding the portal pedicle of the, you have already dissected, come to the area where you have occluded. You want to check if the remaining area, what you're occluding, remaining areas perfused well. So that's where it helps.
Tell us something about thoracic duct also.
Yes. So now
students in between, if anybody wants to ask anything, please unmute yourself and ask. This is an open house session, so please ask. I'm asking these questions on your behalf, but you should be asking these questions. Yeah, Srikanth.
So if you inject ICG, let's say distally in the basically tissue fluid which comes from below going into the thoracic duct. So this could be done at the time of induction of anesthesia. So anything injected into, let's say, the limb also would come into the cisterna chyli and then go up into the thoracic duct. Personally, we have not used it, but it has come up and it's been reported in just few years. The thoracic duct, it's increasingly being used because in MIS it helps, in robotic esophageectomy it helps, and so on and so forth. I guess even in open esophageectomy to identify the thoracic duct, it would help. The interesting thing here is tissue fluid you inject and then it comes into the lymphatic system. You could use it the day before surgery. Similarly to what we do for, let's say, gastric cancer, if you inject in 4 quadrants along the tumor, 24 hours before upper GI endoscopy and inject, next day it is found it's basically getting injected into the submucosa, into the around the tumor in the 4 quadrant areas. It's taken up by the lymphatics of the region and the lymph nodes light up basically. So it would be clearly seen in the lymph nodes. So there we are injecting 24 hours before. And during surgery, it's quite clearly visible. Parathyroids used during the time of surgery. Colectomy, if you want to, urothelium has great affinity for, this is one place where the epithelium has affinity. You have liver which takes up rapidly, but tissues, if you inject directly, it requires a cystoscopy, catheterize the ureters, inject into the ureters. 5 milligrams is what we use on either side, 5 milligrams. And it stays for 4 to 5 hours because the urothelium has affinity for ICG. And during any complex procedure, which might last 3 hours, 4 hours, you see when you put in the ICG mode, the ureters clearly showing up. The esophageal mucosa I was mentioning doesn't have an affinity. So methods which have been devised to increase adherence of this is we mix it with albumin solution. And when you give it in through the Ryle's tube, it just coats the esophageal mucosa. So when we have done a myotomy, you could assess the entire myotomy. Also instill at the time of checking the myotomy, and fluorescent leak can be very easily seen, which we have seen mainly in gallbladder surgeries or cystic duct areas, or when you do a CBD exploration, we see the fluorescent bile, how it looks. So you look for the similar thing when you inject through Ryle's tube for a cardiomyotomy. So that's something we published recently. Urothelium we use routinely for our ureteric identification. As a routine we use, but definitely it makes a big difference in a difficult case where you don't have to have an indwelling catheter to, particularly in MIS where you don't have the tactile sensation.
So going back to thoracic duct again, for the sake of students, this has to be injected into the lymphatic system, isn't it?
It has to be injected into the, so if it is injected into the subcutaneous tissue, it is taken up by the lymphatic system. We haven't personally used, but most of the descriptions are subcutaneous in the lower limb.
Yeah, Shiva, you want to ask something? So you want to say something?
Yes, sir. Yes, sir. I have two doubts, sir. First thing, sir.
Yes.
Is there any dose adjustment for pediatric cases? Suppose being lab coding pediatrics, children, is there any dose adjustment? Second thing, is there any adverse side effect of using this? Any anaphylaxis reported? Because we are not giving any tests for any patient. Is there any adverse effects
Yeah,
of
I
this
think
ICG?
it's an important question. Important question. First thing is, because ICG is inert, that has been the biggest advantage of such a wide usage. But ICG has very rarely shown certain allergic reactions, and this is particularly in people who have iodine allergy or seafood allergy. I mean, these are places where one needs to avoid usage of ICG. But routine sensitivity testing has not been recommended. Having said that, we always keep the backup of your hydrocortisone, antihistaminics, etc. Before we give. We elicit a clear history from the patients about any seafood allergy, etc. So iodine and seafood allergy, you should avoid usage. The reported incidence is 1 in 10,000 for a allergic reaction. The second question is, for ease of use on a daily basis, we talk about 2.5 milligrams in a adult patient, typical adult patient, and that's standard for most of the lab coli. But in pediatric population, even in adults, there is a 0.025 milligram per kg. So something like that. I mean, you have these mentioned 0.2 milligram per kg, etc. These specific per kg, you have these dosings. And the Shanghai consensus gives a table which says for this different indication, this is the consensus dosages to be used. So pediatric, you could accordingly use the dosages and calculate based on the weight.
Can you tell us about the equipment required? Because we need a special telescope. So, which means that do you keep changing between the normal telescope and the fluorescent telescope, or now there are hybrid telescopes available?
Yes. So I think this is the biggest area of development which has been happening. There are good imaging systems now currently available which provide it in the single scope that you can switch from different modes. And in fact, most of them in the commercial use would prefer or would use that. Although in the beginning, this was the biggest challenge, that there you had to switch between scope. Later, the situation came where within the same scope, you have to switch between the modes each time, which that was one challenge. Another challenge was they were not color coded. So you had to see the true infrared images, which is essentially a black and white with a fluorescent part seen. So you had to mentally visualize it and switch back to the white light and imagine where that fluorescent part was, and then say that, okay, so this is where I need to be careful. So subsequently, what happened is the computer takes these images, immediately processes the black and white image where the fluorescent part is color coded, let's say green, then superimpose on the white light image, and the computer generates the augmented image, which gives the real-time white light image, what we are used to during laparoscopy, with only the structure of interest lighting up in the color that is typically green. I mean, you could color code it anything, but it's color coded green. So this has happened in the last several years where you could switch, and you have also the augmented image, which means the real-time white light image with the superimposed, the fluorescent part color coded. So that has happened. But the problem there is this computer taking the image, superimposing and giving you that color coded thing, even that in a fraction of second, it takes a little time. So the lag is felt, if you see. Further thing which has happened is, at least the system we use, picture in picture. So you will have one corner, the larger part of the screen showing you the white light image, which is what we are used to comfortably to operate. And then the left side, the true fluorescent image, black and white, and also the augmented image on the left. So you have an immediate, in a large screen, a comparison of what's going on, and you just have to look at the left side of the screen, you know where, and you're actually using the white light image to dissect. So these are things which have come up and big advantages. Instead of switching, when you switch, you get an impression. When you switch back, you again are not sure. You have to switch back. This is not required in the current imaging systems, at least the one we use. And I'm sure there are others, similar ones. So it's evolving.
What about ICG in open surgery? How do we do it?
Now, if we need to speak about liver resections alone, I would still think that most of the work is being done in open surgery only. I mean, these descriptions they've used. Now, like you have some of these, the instrument, the scope lengths are shortened for open, to make it easy for use during open surgery. But the same laparoscopic camera has been used by many groups to, these are available. Basically, to 23, you have, like, for example, the length of a scope, if it is around 40 centimeters, you have it at 25 centimeters, the shorter scopes. So parathyroid surgery, they use that. Open liver surgery, they use the shorter scope. But in terms of how it works, looking at the monitor and looking at it, it's similar. Both are similar. Scope lengths are available for open and lap. That's one thing very clear.
What about assessing the viability of a conduit, say gastric conduit or colonic conduit?
So for bowel vascularity, for gastric conduit vascularity, I think it is an assessment of injection and looking at the perfusion. This typically happens within a minute, which means you inject intravenously and you look at the flow within the conduit, the perfusion, the color that shows up, the change in color, fluorescent color. So I think it's being used for gastric conduit. It's being used for when you do anterior resection, the margin, proximal margin of transection for that purpose. I would still think it is investigational in terms of when you ligate the IMA, for example, in a minimally invasive resection, people are, I mean, there are groups which are cannulating the distal IMA. Put a bulldog there and inject. That will show the segment which is coming out, the vascularity of the territory, tumor-bearing segment just showing up, the edges of it. So, I mean, people are using it both ways, which means inject systemically. You have already occluded the IMA. You know the vascular proximal part. You can also do it through the IMA, which is more technically difficult and so on, but it can be done.
But this is all very subjective. There is no objective measurement of the fluorescence.
This is where our experience is less, the bowel anastomosis area. And somehow when we have used it, we have felt, you said subjective. I think that's the problem with the bowel anastomosis, I feel. You can't be sure. I mean, you can say that, see, the flow looks good here, but where does it actually end is not clear. But when you do anastomosis, you give the ICG, that the anastomosis is well perfused, that area, that you could say. But that exact transition, we have had difficulty in making out.
But suppose you have divided the colon, say, for a low anterior resection, and you do ICG, and you don't see any fluorescence, then at least you are sure that this is not a vascularized part, and you need to resect more.
I think it definitely helps. It's just that we have not had much experience there. If you inject, you will see the fluorescent part and the no uptake part. And you could err on the side of taking more on the fluorescent part, maybe, to be sure that vascularity is good till there. So definitely, I mean, there are groups. I mean, I'm amazed at the number of publications. Initially, it seemed a little, what do you call, market driven, or it felt like that for me 4 years before. What is this? Every journal comes up with 3, 4, 5 of these ICG ones for bowel. Is it because it's a new gadget and everybody is using it for? But I think there are definite applications. It's evolving rapidly in those areas.
Okay. I think we just have few minutes. So any of the students want to ask anything which I may have missed on your behalf? Any student wants to ask anything? Yes. Please identify yourself and ask.
The screen is still not visible, right?
Yeah, I think you need to take help of somebody to, or is it because you are using a Mac? Maybe
I'm using a Mac and maybe I'm not aware of what. So,
yeah.
because I
So
just wanted to show one or two videos to highlight, but that's fine, sir.
maybe if you send it to Avinash, he will post it on the JST website.
I will.
So Navendu, Bigyan, Praveen, Sandeep Dave, Shubham, Shiva, anything you want to ask? Please unmute yourself and ask if you have any doubt in your mind. Any of my residents want to ask anything?
Sir, no, sir. Krishna and Monil don't want to ask anything.
Okay, okay.
Yes.
Any of the faculty members want to add anything? Rajen, you want to add anything?
Sir.
Yeah, Shiva, go ahead.
Sir, sir, is there any specific time interval for luminance ICG reduction? For example,
I didn't get the
to assess the
question.
liver parenchyma, we are given within seconds to minutes. To assess the gastric and colonic, that's what is the specific time mentioned.
No, I think Dr. Srikanth already said that if you want to assess the vascularity of any organ or any conduit, then it is immediate. So you inject intravenous and then you look
Within a
for the
minute,
flow.
you should be able to screen. Yeah.
Within a couple of minutes. Yeah.
Okay.
Sir, I would like to request Srikanth sir to send us some papers, PDF files, so that we can also update our knowledge. I'm very poor at ICG because I have never used it. So
Yeah,
it
so
would help
Srikanth,
if you
maybe
gave
you
us some
can,
journal.
you can suggest one or two good recent reviews or guidelines which cover all these things so that the students can benefit and we can also read
Offhand,
more
I
about
will
it.
definitely send it across, sir. But I think what is available as open access is one is the Shanghai Consensus. I think if you read that, you get an overall picture in hepatobiliary surgery. Shanghai Consensus. It was published in Annals.
If you can send it to Anand or Avinash, maybe then we will post it on the GST.
Yes, and
Or
second one is Dip et al. It's from US. So this again is a multi-continental consensus group meeting which happened, and that is ICG for use surgical in surgery in general, which means in general surgery.
That will be more useful to the students.
Yeah.
Because very frequently now this question will be asked in the exam and students ought to know about various uses. So if you can send the PDF of these two articles to me or to Anand, then we will post it on the JST group.
Yes. So one brief thing about it, it's interesting. How it works is basically it's a anion, it's an inert substance. When you put white light, you can't make out because you can't make out. Infrared component, if it hits this ICG, it just reflects back excited waves which are picked up by the camera, infrared camera. And it's been used for night vision when night safari, night vision, the army, so on and so forth. So this has been adapted for use. It was approved 7 decades before by FDA for clinical use. And it's surprising that it took till 2008 to come, for putting it to greater use actually. So it's taken time and it's going to rapidly evolve because of the technology which is really evolving in this area. I will forward these papers, sir.
Sure. Okay. I think we will close the session there.
Sure.
It's already 11:30. 11:30 for me.
Thank you, sir.
Thank you
10
all.
o'clock
Thank
for
you
all of you. Okay. Thank you. Thank you, Srikanth. Thank you very much.
You're welcome, sir. Thank you.
Thank you. Okay. We'll close. Anand, can we close?
Yes, sir. Sir, we can close, sir.
Okay.